My name is Khalil. Admittedly.
Sager, are we missing anyone? Oh, got everyone.
David Lee, I think.
Yeah, he's out of Wi-Fi service at the moment. Thanks for joining us, Ms. Francis. You just missed the talk. Dr. Coleman, how are you, ma'am?
Hi, I'm still at work. So
I hear you. Thank you so much for joining us.
Alrighty. Well, good afternoon, everybody. I would like to welcome everyone to the fourth week of our summer lecture series and our journal book club. My name is Warner Goldberg, and I will be chairing and moderating today's session. Today's featured speaker is Dr. Nailah Coleman. Dr. Coleman is an associate professor of pediatrics at the George Washington University School of Medicine and Health Sciences, and a pediatrician and sports medicine physician at Children's National Hospital. She also conducts her own research, focusing on in-process improvement, youth health and fitness, and health disparities. Welcome to our session, Dr. Coleman, and feel free to take the stage whenever you're ready.
okay. Thank you. Thank you for having me. I always enjoy every year coming. Can you hear me okay?
Perfect.
Okay. We've got lots of noisemaker things to deaden sound so nobody else can hear me inside this building. But let me know if you struggle to hear me, and also let me know if you have any questions. Feel free to just raise your hand. Okay, let me see, I'll share my screen. Okay. So today I was going to talk about the perils and pitfalls of the pediatric musculoskeletal evaluation. I think there's a lot of things that we kind of tend to forget to do, or we kind of let go over time. So we'll just kind of think about the things that we should be doing. So the first is objective is hopefully you'll leave kind of remembering how to perform a general MSK evaluation and list important things to consider when performing that evaluation. And then think about the pitfalls that we can all kind of fall under when we're performing an MSK evaluation. So the first thing to think about is when patients come in complaining of some kind of bone or joint problem, usually it's because something hurts. And usually it's because something just started hurting, but sometimes it's a chronic pain as well. Every once in a while, somebody will come in saying that there's something that looks different than it did before, or it's not where it should be. Usually that's not, it's just deformity, but also it's because it hurts too. Usually it's not just a deformity. Sometimes it's because it doesn't work the way they used to be. So maybe they're complaining about weakness. And then sometimes, you know, they have a concussion, they were hit in the head, they're acting differently now. And then sometimes we have people who come for a more positive reason, you know, so no bone or joint problem at all. They'd like to start a new physical activity. Maybe they had a history of a knee pain or knee problem before, and now they want to make sure they're doing everything they need to be a successful athlete in their new sport or in a sport at all. So when we come back to acute injuries, that's I guess probably the most exciting part. There's more to think about, you know, what happened. And it's always good to ask a detailed description of the injury. I encourage people to think about it like, well, if you could describe it again, if you could make a movie from the description, would you be able to? So, and would the movie look the same for each person who heard the story? So you want it to be so you can kind of picture it. So video is very helpful. You know, a lot of people now have a phone that they recorded something, or so that's always something to ask. If they don't remember what happened, ask, is there video? Hold on, I'm gonna move my thing because I can't see. Okay, so after why comes where and when. So where is the pain? You'd like for them to point with one finger for where they say it hurts. You don't want them to tell you where it hurts because they did not take anatomy. So where they say it's their shoulder, it could be their back or their neck. So it's good for them to point with one finger. They can point to one location or multiple locations, but always have them just use one finger instead of just kind of waving their hand over an area where you still just have no clue where it is. You can also ask them if it starts one place, does it go someplace else? Radiation is fine to know, but you want to know, first of all, where does the pain start? You can ask about timing. Has this ever happened before? Is the pain intermittent or continuous? And how long overall has this pain been bothering them? What is the character of this pain and what's the course of this concern? So The character is nice actually, because sometimes when the patients give you their character of their pain, they will also give you a clue to their etiology. Burning pain often is associated, although not always, with neuropathic pain. Kids with Osgood-Schlatter or calcaneopophysitis will say it feels like someone's hitting them with a hammer. So there are certain things where they will always kind of give the same description. So that's kind of helpful. Pulling pain can be usually a sprain or a strain. But it's good for them to kind of give you an example of how their pain feels, because in the end, when you have them do rehab of some kind, rehab is usually not pain-free. Rehab can make them sore and stiff, and you want them to distinguish that rehab pain from their true pain. So it's good for them to say, you know, it's sharp, rehab makes me sore, versus I just have pain, rehab adds to it. So that's why it's good to give the different characters. Also, you want to know, is it better, worse, or the same? That can be helpful. Then you know how much you have to do when they come in to see you. So what makes the pain better or the concern better or worse? And these can also just be helpful because you might just say, well, let's continue these, right? So if they've been doing heat and it helps, they've been doing ice and it helps, continue. If they're taking a medicine, ask them really what kind of medicine, how much are they taking, how often. I always counsel them not to take medicine pre-athletic event, so that way if they have pain, it's a good indicator that they should stop playing. If they're medicating their pain before they play, then they could hurt themselves worse. Rest is often underutilized for pain control, so having them really take a true rest can be helpful. Massage is nice. They can go to physical therapy. And then there are different modalities and stuff that they could use there. And then have they tried any equipment things? Have they tried changing shoes? Have they tried to change in their training? Have they tried playing, you know, outside versus inside? All those things can be helpful. And there are things that you can kind of encourage them to do if they have not tried. And then think about other things that could be aggravating their pain, other activities that could aggravate their pain. Sometimes sitting for too long can aggravate their pain, and that can sometimes be a clue to what's going on with them. And then obviously direct pressure can cause pain. Does it affect any kind of part of their regular day? So does it affect their function at work or at school? This is important, partly just because it gives you more of an idea of how it's affecting their lives, but also it might lead to notes for work release or workman's comp or for school restrictions. Other things, does it affect their athletics? Does it affect certain sports and not others? Do they have issues with bowel or bladder dysfunction? You'll particularly want to note these if you have a concern about any neurologic issue. And does it affect their sleep? Because definitely if they just had an injury today or yesterday, they might have sleep disturbance because of their pain. If they had this injury a couple months ago, they should still not be having sleep disturbance from their pain, from that injury, I should say. Any effect to sensation? If they do, you want to ask them to outline for you the area where they say it tingles or it's numb. Oftentimes, as part of our pain response, we might have decreased sensation to the area just to decrease our pain, but then they can have a numbness or a tingling sensation in the area of pain. So if it's only there, then it's less concerning than an area that's outlined like a dermatome. You can also ask, depending on the issue, does it affect their balance or their proprioception? Is this concern related to anything else, right? Because people get hurt all the time, especially I do pediatrics. Kids get hurt all the time. They fall, they bump things all the time. Not all of those kids come into the clinic to see me. So I want to make sure there's nothing else that could be causing this pain, and then the injury was just an extra. So I ask everybody about fevers and chills, weight changes, fatigue, and these are nice, quick yes/no questions. Headaches, vision changes, balance problems, chest pain, shortness of breath, any GI things, so nausea, vomiting, diarrhea, constipation, appetite, GU symptoms, skin changes, rashes, and anything else hurt. So those are all the questions that I ask, and I ask them almost just like that. And if it's truly like an MSK issue or just truly an injury, the answers are all no. Every once in a while you'll get a yes because they had a cold and they had a fever recently, but for the most part, you'll get no's to all of those if it's a true MSK. If they have multiple answers of yes to multiple categories of concerns, I tend to worry that there's something else going on. I'll also ask them, have they tried anything else? So there's the things that they might have done on their own, and there's the things that they might have sought somebody's help to do. So they could have gone to PT or OT. They could have worked with the athletic trainer at their school, which is great because if they have an athletic trainer, then I can work with the trainer to help them return to sport. Chiropractors are often covered by insurance companies, so sometimes people will have gone there. They might have had surgery and then they're back here with a new problem or a problem related to their surgical procedure. They could have tried alternative medicine, so acupuncture, acupressure, massage, hypnosis, or yoga. And then the thing to ask if they tried all those things is that, did it help? Because if it did, then that's, a reason to return to those things if their pain has recurred and they had stopped working with those people. Other things to ask about, especially with kids, because they're kind of newly presenting with things, is do they have any past medical issues that might affect their treatment? So any MSK disorders, so osteoarthritis, rheumatoid arthritis, or JIA, fibromyalgia, any rheumatologic disorders like lupus, psoriasis, mixed connective tissue disorder, any endocrinology issues, diabetes, thyroid issues, any neurologic or psychiatric disorders, so restless leg, post-CVA, anxiety, depression, and with cerebral palsy, or a history of concussion, and any other medical conditions. So cardiac, pulmonary, reflex, anything that might actually impact your treatment of them. Have they had any surgeries, MSK or otherwise, especially if you're leaning toward their need for surgery, you want to make sure that they've handled surgeries well in the past. Other things to ask when you're thinking about surgery would be, where are they in their season? Where are they in their life of sport? And what are their plans? I'll also ask about what medicines they're taking now, and for what purpose and for how long and how much. Because definitely somebody can take an anti-inflammatory medicine acutely for a new injury, but somebody might be taking an anti-inflammatory medicine to manage their ongoing lupus. Same thing for analgesics. Do they take them chronically for their headaches, or do they just take them now for this concern? Because that might change your recommendations. It also might change your dosing. Were they prescribed any antispasmodics for this concern? Have they used them? Were they helpful? Any anxiolytics that they take? Anyone who's on an anxiolytic, you want to make sure that it's controlling their condition. Otherwise, controlling their anxiety might make might be necessary to make sure that their pain is also controlled, because people who have a mood disorder, anxiety, or depression that's uncontrolled, it's very difficult to manage their pain. Any anti-neuropathics that they take, who's controlling that treatment, and do we think changing that treatment would be helpful? And anything else with any other diseases that could be impacting their care with you. And obviously allergies and intolerances if you're considering prescribing something. So putting it together when you're thinking about your history, thinking about your pearls, you always want to ask the patient where it hurts the worst, and then also where maybe it goes after that. Always get a detailed mechanism of injury, and always get a complete review of systems. The pitfall is presuming that you know where the pain is, versus asking the patient to show you and not tell you. Assuming a fall is just a fall, versus a fall being something else that happened to them, or that they really had nothing happen to them, and this is a medical problem and not an MSK concern. And then assuming the pain is related to an injury, same thing. So as a case, there was a 15-year-old girl who was a cheerleader who came in to the ER and complained of knee pain. She was stretching, she said, after cheer practice, and she started feeling pain in her knee. Unfortunately, that story, cheerleader pain at practice, got passed along, and nobody really confirmed the full mechanism of injury further. And she actually did not have a mechanism of injury. She was just stretching. In the end, she had a septic knee, and it was unfortunately delayed. The diagnosis was delayed because they never confirmed that she had no mechanism of injury. So it is important to kind of make sure you're doing those things, even if you think that you know what it is at the beginning. So on exam, obviously you want to get their height, their weight. It's always nice to have a BMI, heart rate, blood pressure. Depending on the other concerns you have, you might get a temperature. Comment on their general appearance. Do they look well? Do they not look well? Are they overweight or obese, underweight or cachectic? Those are all important things, and they can lead to a different diagnosis that you're thinking about. And then what is their affect and mood, and are they congruent? So when we do our exam, we all just kind of want to get in there and touch it, and you really want to try not to touch it right away. If you can, kind of clear the area, so make it naked. If it's a knee, you want to look at both knees. If it's the shoulders, you want to look at both shoulders as best you can, depending on where you are. A lot of times in the emergency room, it's hard to do a completely unclothed exam of the area, just because a lot of exams happen really in a hallway. So it can be difficult, but you want to do the best you can. When you are inspecting, you have to remember that inspection starts when you first interact with the patient. So that can be while you're doing your interview, if you're able to watch them walk down the hall, those are all ways to observe. Watch if it's their shoulder, how they take off their shirt, how they take off their jacket, if they're holding something, how they sit down, how they get up. All those things are ways of inspecting how they're moving. You want to see if they have ease of movement, if they have comfort. When you clear the area, you want to look at the overlying skin. Is there any erythema? Is there edema? Is there any deformity? And do they look the same if you're comparing both sides, which is always recommended. You want to check their range of motion, just thinking about what the joint should be doing and can they do it. Active is the best to check, and if they can't do active, you want to check passive, except for with spine. So active first. You don't always need passive unless they lack full active motion. When you're describing it in your exam, you want to be as specific as you can and relate it to something else. So relate to neutral position. You can relate to some other position on the body, or comparing to the other side, or to somewhere in the environment. So, parallel to the ground. And then you want to note why, if they have limited motion, they have it. So is it pain? Is it restriction? So an example, if you have somebody bend over from the waist for forward flexion, lumbar flexion, and they can only get to touch their knees with their hands, you want to ask why. Does it hurt? And sometimes they'll say, oh no, I'm just not very flexible. This is as far as I ever get. So that's just something to think about, because then that might just change a little bit of your treatment plan if they have back pain, that they need to add some extra stretching. So then once you've kind of just looked at it, you want to think about their function. So how easy do they move it? And then can they do some of the simple things you ask them to do? Can they, do the duck walk? Can they hop? Can they do these different things? You also want to check their strength, and I usually try to check their strength against gravity. So at least they've at least got 3 out of 5, and then move on from there. How is their sensation? Check their reflexes, particularly if you have a concern about a spinal problem. Check their neurovascular status, and then also check the stability of the joint that you're testing. Is there any increased translation? Is there decreased translation? Is there pain when you test, although normal motion? And pain may or may not be associated with increased translation. And then obviously for every joint, there's a special test named after many people. And you can use some of those to sometimes confirm your diagnosis or rule out others. So kind of universal kind of thinking about special testing could be like apprehension test. For instability, there's 3 different apprehension tests in the body. You can do Tinel's test for any kind of peripheral nerve irritation. Laxity assessment can be done in all the joints, impingement testing, and then joint specific special testing. So you have your opportunity to kind of do more than just the range of motion, sensation, strength, and special and ligament testing. You can do other things as well. So once you've kind of done everything you can before having to touch it, then you touch the joint, and depending on the joint, you'll touch earlier than later. The reason why you want to palpate last is you don't want to irritate an already painful area and then affect the rest of your exam. So if you started off touching their shoulder and then you made it hurt worse, and then you say, now let me see your motion, and they refuse or they can't because now it hurts more, then you've ruined your exam. So that's why you want to palpate as close to the end as you can. You're feeling for edema. So if you see edema, you can also maybe feel it. For effusion, looking at feeling your deformity, thinking about the consistency, the size, and is it mobile. You can confirm if you feel the asymmetry that you see on exam, or if you feel asymmetry that you did not see. And obviously you want to note tenderness. So then you're thinking, okay, well, should we get an x-ray? But you want to make sure there's nothing else that could be bothering them. So there are certain times where you might do a secondary survey, or you might test an area that's near, or the area that you already had looked at. So with knee, we would usually do hip. With shoulder, you would usually do neck. So you'll do other things. You want to make sure you do all that before you order any diagnostic testing. So when thinking about your exam, your pearls, or compare with the uninjured side, if you can, you want to be a naked exam. Perform a complete MSK exam, or I should say a composite exam, where you test for all the components of the exam, and then do a secondary survey. And then the pitfalls would be focusing only on the area where they say it hurts, checking only 1 or 2 components of the MSK exam. So if you're thinking, oh, it seems like this is an ACL, and only testing for ACL and not testing for anything else, you could miss other injuries. And then assuming if the patient is not complaining about it, it must be okay. It's good to check it just in case. So an example of kind of thinking about your exam is a 13-year-old boy came to clinic who had knee pain, and he complained actually of bilateral knee pain. He'd had knee pain for a while. He actually complained about swelling and redness in both of his knees, and he'd had this for a while, and we examined his knee. His knee was fine. And we actually also examined his hip, but if you missed his hip, you would have also missed that he had a skiffy. So it's always important to examine both things. So when you've done your history and your physical and you're thinking about diagnostic studies, either to rule in or rule out something, there's different things that you could order. The most common thing that we do is order x-rays. Usually we get an AP and a lateral as standard views, but you might also get an additional view if needed. Some come with that third standard view, some do not. I recommend that you order the views that you want, that you specify them. That's depending where you are, depending on what site you've got. Sometimes they will have standard views that they order that are not what you would want. So it's always better to specify the views you want so you get the information that you need to make the decision the best decision for this patient. For kids, because of the growth plate, you might need comparison views. And sometimes radiology will say that comparison views will be helpful. Sometimes if you order them already, they'll say, why did you order them both? So you have to kind of go with what you're thinking. But if you have easy access to the patient and x-ray, you can order just the one. But if you don't have easy access to the patient and x-ray, you might order comparison views at baseline just to make sure that you can evaluate how the growth plate looks in the injured and non-injured area. Very rarely do we get CT, but you might get CT to look for bony anatomy, things like tarsal coalition. You can also see that sometimes on MRI, but MRI we typically get for soft tissue like meniscus, rotator cuff, disc problems, and spinal cord problems. For most insurance companies, you're going to have to get an x-ray first before you can get any secondary study like a CT or MRI. You can also get bone scan if you're worried about a cohort fracture or other lesions for your oncologic concerns. For people who answer yes to their review, to many things in their review systems, and I'm starting to think that they have lupus or something like that, I will start to add on additional testing. I almost always will get a CBC, CRP, and SED rate. I might then add on an ANA rheumatoid factor if I'm thinking that it's rheumatologic. I might add an ASO, Lyme titers, or EBV titers if I'm thinking more infection. And then there are people who have metabolic issues. I might order a vitamin D, calcium, and a phosphorus. I think I've ordered uric acid a couple times in pediatric patients. I think I order that more. I used to order that more in adults. Additional things that you might get if you're thinking that this patient has complex regional pain syndrome, you might get an EMG with nerve conduction velocity. If this patient has other complaints and you're thinking, yes, you have knee pain, but I'm also worried that you have some other problem that they said that they had chest pain and shortness of breath with physical activity, then I might add on referral to cardiology for consideration for EKG, echo, or stress test. And same thing if someone has difficult to manage exercise-induced asthma, I might send them to pulmonary for PFTs. So when you're thinking about your imaging and your labs and you're thinking about pearls and pitfalls, for pearls, you want to specify your radiographic views. Remember the growth plates. And when ordering lab, and you want to order labs if you think that maybe they have infection or inflammation. And those are the people who answer yes to a few of those review of system answers. For kids, you can also think about ordering labs if you have a positive family history. So if their aunt and their sister both have lupus, and this patient now has knee pain without injury that bothers them more in the morning, then you also might consider labs. Pitfalls are just going with the standard views versus the views that you really want to see, the things you need to see. Calling everything a sprain and assuming it was only due to an injury and nothing else. So another case is a 10-year-old boy who came into clinic with knee pain. He'd had knee pain for a couple months, no injury. He didn't play sports, actually. He'd been very tired, and he'd had some fatigue and some anorexia, and I think he'd had some weight loss. And actually, I saw him, and when he came to see me, he had not had any other studies done. And so I did order some x-rays and some labs, and he actually had leukemia. So it is something to think about, that not all people who come in with knee pain, especially young people, or any kind of joint pain, have a primary musculoskeletal concern. So when you're thinking about pearls for your diagnosis, you want to make sure you're really using the history, the physical and the diagnostic test to formulate your diagnosis, and then later your treatment plan. The pitfall really is diagnosing too soon and thinking they said they fell, or I've had patients tell me, well, I must have heard it at some point. And if you don't have a big injury mechanism and somebody comes in with significant pain, then you have to think, is this something else? So when you're thinking of the diagnosis, you want to keep an open mind throughout the evaluation. You want to try to avoid calling everything a sprain, because I know that's the easiest diagnosis. And when students and residents and fellows come to clinic and they say it's a sprain, I challenge them to tell me the ligament that was sprained. Then, so that way we can make sure we all know why they're saying what they're saying. And then obviously for young people, you want to remember the growth plate. Questions?
Hello, Dr. Coleman. This is Borna Goldberg, and I am a recently graduate student from and got my bachelor's in kinesiology, exercise science. I just want to say, wonderful presentation, and I do have a small question, relatively. So I noticed that majority of the assessments focus on the skeletal, muscular, endocrine, and systems that are more like biophysiology related. Nevertheless, has there been a concrete system that, especially in young athletes where we see the rise of depression, mental health, and anxiety, has there been a concrete system or assessment or questionnaires that determines the level of their mental health and the current state of mind?
That's a great question. In the pre-participation physical evaluation, they've actually added the PHQ-4, which has some questions related to their mental health. So when they get the PPE, if you use the official screen, that you will get that there. We use in our clinic for kids at 12 and up, at least for well visits, we use the PHQ-9, which includes a suicidality question. Actually, we use a modified, so we actually have a few other questions to see how it affects them. If you're thinking more anxiety, you can use a screener like the GAD-7. There's other ones out there, but those are the two common ones. And that's, the PHQ-9 is 9 questions, the GAD-7 is 7 questions, but they're pretty quick to administer and for the young people to fill out and for you to tell if there's a concern. So there are ways to do it in clinic especially if that's a worry that you have, or you tend to have athletes who are really struggling for that year. And we've definitely seen that increase. So you can add those two screeners to or other screeners, there's other ones out there, to your kind of workflow, so that when they check in, they get the screener, they can fill it out, and then you can review it with them while you're also kind of reviewing with them their concern for that day.
Perfect. Thank you so much.
Hi there.
Sorry to interrupt. On that note, Dr. Coleman, do you revisit that and ask to fill that out, the GAD-7 and the PHQ-9? Do you give it frequently? Say hypothetically covering a high school or something then.
So we give it for well visits every year from 12 through 20 when we send them away through 22. And then we will also, if we're concerned, we'll give it. We're blessed in our clinic to have our psychology team here with us. So if we have a concern, we will ask the young person if we can have them kind of come and meet with our psychology team briefly, and then they will set up an appointment to work with them at some other time. But we will address it again, and we'll bring it up at that time. In our regular well visits before we started doing the screeners, we just would ask if they had concerns, if they felt depressed. And you can always just ask that, do you feel depressed ever? When you feel depressed, what do you do? Do you talk to anybody? So you can always just ask that too. It's important to kind of think about who they're with when you're asking these questions, where you are. Because sometimes, depending on where you are, it's harder to get that good response from them. So they need to feel safe in that area where they are too.
Hi, thank you so much. I really appreciate it. I'm Gabe Ramos. I'm a rising M2 at UVA. And I just had a few questions about, your methodology when you're ordering imaging studies. I know that, sort of as things progress, the 2 view is the only view kind of deal, right? But I've been reading a lot about, especially with musculoskeletal injuries and other involvements, that people are starting to turn more towards a tertiary approach where they're doing, an AP, a lateral, and an oblique.
Mhm.
In what cases do you see that catching on? Do you think that that's valuable? And then I would also like to know a little bit more about what you think about, a conjunctive ultrasound in order to assess for soft tissue damage alongside a radiograph.
Let's see. So I think for most things, although I guess maybe it's more medical, we just order 2 views, AP lateral chest, actually I guess spine, we tend to order AP and lateral. Depending on what you're looking for, then you also might get that extra view. So like lumbar spine, you might get the obliques. It depends on the patient. And if you think you'll get a good view with your oblique, without the obliques. A lot of joints you might order just the extra anyway. So ankles, you're going to order a third view. You're going to order your mortise view. With feet, you're always going to order that oblique view. So some joints will always have a third view kind of at baseline. Wrist, you can order 2 or 3 views, but you really want to specify what that third view is, because sometimes if you say 3 views, they'll give you a scaphoid, but you don't need that. So you really want to think about what you want to order if you need a clenched fist view or something like that. So if you don't know the name of the view, you're like, I don't know, I want to see this thing. You can, well, Google it. I'm sure it's there. But you can also call radiology and just ask to speak to the radiologist who's reading x-rays that day. And then they can help you know what view to specify. Oh, ultrasound. Well, I'm a pediatrician and I work in a pediatric hospital. So actually I don't do a lot of ultrasound. There's, I guess, kind of increasing use of ultrasound. And I will say there have been times where I'm like, oh, if I could have just had an ultrasound, I could have said what that was. But I don't tend to use it routinely. And I think in general in pediatrics, we don't tend to use it routinely, but other clinics do use it. And I think people tend to use it more, not for diagnosis, but for doing something with the ultrasound, whether it's giving injections and stuff like that.
Hi, Dr. Coleman. First
Oh,
of
I'm so
all-
sorry.
Oh, sorry.
After you. No, I'm so sorry.
I want to say thank you. That was a great presentation. And my name is Sarah Francis. I just graduated. I have a degree in public health and neuroscience from Tulane University.
Right.
And I was wondering, in terms of pediatrics, you mentioned looking at underlying issues. And when looking at the relation with those underlying issues, how do you deal with the subjective nature of pain and when children are self-reporting when you're doing that exam?
Well, that's a good question. So, a lot of people will ask them, well, so what level is your pain? And actually, to me, unless I'm going to treat the pain and make the pain less that day, the level actually is less of a concern for me that day. If they have pain and it's a 1, but it bothers them, it bothers them. So I just treat the pain. If they say that they have pain, then they have pain. And then I just help them feel better about it, and hopefully try to alleviate the pain. So I just kind of go with that. I do think about their, you do want to think, if you're starting to do your evaluation, you're like, well, you've got a normal exam. There was no injury. There's nothing, your review of systems is negative. Then I start to worry, is this a young person who maybe is trying for attention or something like that? But I will still do my full exam. I'm going to make sure I don't miss anything, because the less hurtful thing is to say, oh, it's just in their head. So if you forget that and you miss that, then that's not a bad thing, right? Versus making sure that it's not because they have growing pains where they can benefit maybe from some stretches. So I will always try and make sure that I really consider their pain valid. For the most part, I don't really ever say that their pain is just in their head. It's very rare for me to say, well, I think he's kind of just faking it. Most of the time and trying to get attention or something like that. Most of the time it's because there is something going on for them. And some people, I had a young man who, he kept having pain, he kept having pain, he kept having pain. We did all these things and he didn't want to play. His mom wanted him to play football. He didn't want to play. And so I finally said, you know what, why don't we just kind of do some rehab, take a break this year, and then you can maybe reconsider for next year. And he was like almost instantly better. He just didn't want to play. So you have to kind of think about those things, but I always make sure that I'm not missing something. So I always consider their pain valid when they come in. Did I answer your question?
Yes, thank you.
Okay, good.
All right, I have a question. I guess with the advent or the occurrences that are occurring not too long ago. Obviously, we're concerned with the inflammation of the heart, status post-COVID. How prevalent have you seen organic heart disease screenings? Are you finding that it becoming more prevalent, or maybe because of the lack of involvement in sport that we've seen with the lull found with COVID and post-pandemic, is it less? And do you find that you're encountering that in your clinic?
So my clinics, no, I'm not finding anybody who has any kind of primary heart condition more than from before. There were some, but not many. I think the data from COVID is that really there haven't been continued issues with cardiac issues related to COVID in our athletes. So we don't have to, I know we were all worried about that in the beginning, and we don't have, that's less of a worry than we thought it was. But we're not seeing any more than we were before, anecdotally.
Great, thank you. Good, Borna.
Alrighty, thank you so much, Dr. Coleman, and please feel free to give us a visit again. It was an absolute pleasure having you, and we're now going to be moving on to our next presentation, which is going to be Mr. David Kim. Mr. David Kim, please take the stage if you would like, whenever you're ready.
Thank you. I'm going to take this time to share my screen. Sure. Can everybody see my screen? Okay. Well, hello. I'm David, and my article was on the concussion in youth, rugby union, and rugby league, a systematic review. So this article basically went into a little bit of background about rugby, and how it's like a compulsory sport and how it's very popular in the UK. They were concerned about the long-term consequences of injury sustained in children while playing rugby, and they reported that concussion is a frequently reported injury. So they decided to do a systematic review based off of previous studies to better understand the incidence rate of injuries in the youth rugby union and rugby league, and also factor in what percentage was concussion as a proportion of all injuries. The methods they used was a systematic review conducted in accordance with like the PRISMA, and the databases that they reviewed were PubMed, Embase, and Sport Discus. The article also pointed out a standard definition of concussion that was adopted in the Zurich conference in November 2012, which I posted on the right. This is significant because during this review process, they noticed that a lot of the studies, there was no definitive definition of concussion that was followed, and a lot of them used different definitions. So next. So the inclusion criteria was that as long as they had the reported data on child or adolescent rugby union or rugby league players with data of incidence of concussion and concussion as a proportion of all rugby injury, and the age was less than 20. They utilized the methods developed by a previous paper in Perek et al. To convert the incidence rate to probability of injury sustained for a player over a season. And that study that was mentioned, they used the Poisson distribution. So they got, using their methodology, they got figures, numbers, and they converted those numbers from incidence rate to hours per hours played into a certain percentage over a season, and they found it to be 0.3% and 11.4% for the rugby union, and 7.7% and 22.7% for the rugby league. Probability chance that they were going to sustain an injury while playing for the season. The chart to the right shows the concussion as a percentage of all injuries, which I've highlighted in yellow, and you can see that it's a pretty significant percentage, although it varies pretty significantly based on the study. So the review basically stated that there was a significant evidence of risk in concussion with children and adolescents playing rugby. What was also stated was that the surveys distributed also found a high prevalence of prior concussion among the players. the number was around 48%. But however, they did acknowledge a lot of limitations with their study. One was that there was very little research on the phase of play to when they sustained the injury, the player position, or the sex in relation to concussion risk. And meta-analysis was not possible due to the heterogeneity of the studies. Like I mentioned before, multiple studies use different definitions of concussion, and there was a lot of different factors, different data collections, different methodologies used, and due to that, they acknowledged that there was a lot of limitations with this systematic review. So continuing with that discussion, due to the high variation, they said this review is not as valuable as it should have been, although they do acknowledge that the high risk of injuries sustained in children that are playing rugby. They also acknowledge that there could be an underreporting of injuries, particularly when the concussion did not involve loss of consciousness, due to the fact that this is less visible and a lot of students or kids tend to just shrug off injuries, or they just want to be eager to play. One interesting thing that I noted from the article was that they stated there was no hard evidence of protective equipment protecting against concussion. So I looked a little more into that, and I looked at another paper, McIntosh et al., which pretty much reiterated this review, stated that there was other studies done where they discussed like high grade like protective equipment versus like no equipment. And they said there was pretty much no overall statistical significance, but every study that I looked at also happened to say that there was a lot of limitations with each study. One example being like poor compliance with protective equipment. So for future research and future needs, there needs to be improvement in data collection and more synonymousness, so there's no heterogeneity, so more like definitive conclusions can be reached. First aiders need to be educated and need to be provided with current up-to-date protocols to best treat injuries when they arise. And some public health approaches need to be taken regarding is such a violent sport, or is there some methodologies that can be used to limit the number of injuries in children when involving rugby. And these are the references. And is there any questions?
Well, I'll comment a couple things. One, this paper was done quite a bit ago. A lot has occurred, particularly within the sport of rugby, even of both formats, union and league. The issue is that also the concussion statement that they cited, the fourth, we're up to the sixth now, which just occurred in Amsterdam. The importance here is that they have attempted to remove the heterogeneity. They're trying to emphasize more of interstudy comparability, and they're emphasizing that so that this way the data is collected appropriately. That's something that not only the overarching governing bodies are emphasizing, but individual sport governing bodies as well, such as World Rugby, FIFA. They're making sure that the data that they're collecting at the adult professional level is also being collected at the youth at the same standards. So this way we could probably have that interstudy comparability. This will obviously, like you said, Mr. Kim, that it will benefit the overall understanding and get out of that first stage of the sports injury prevention cascade, which is step one is just collecting the data. Step two, looking at the trends. Step three, trying an injury prevention protocol. And then four, obviously employing it. So that's where you're at. We're just still at stage one where the world is now collecting data appropriately by the governing bodies, which is kind of unique with a sport that is very old in this area. But again, there were a lot of discrepancies between different countries and how they wanted to collect the data. And only in the late, I guess, 2006, 2000, I guess we want to say 2004 to 2010 is when they came out with the consensus statements. on all the different sports, winter sports, rugby, soccer, cricket, on how to collect the data appropriately. And that's really kind of where we are with things right now, where the past decade is where things have really gotten really good, where we have now highlights of data sets that reflect this kind of data that can be used for injury prevention. And earlier on, it was very difficult to do this, but people were trying to get these systematic reviews out, which they consider the top tier of literature to compare, so that this way they can actually look at what this was done and now we can do it better. And pretty much is what they did with this paper. And again, we know the group, they really are against tackling in youth, and they want stronger rules and regulations for youth. Professor Alison Pollock is a very big advocate on trying to prevent youth rugby from being played per se, to mitigate the injuries that are occurring in their youth or the long-term outcomes. And this is something you need to know about this group, that they really want to try to intervene, I guess only here in the States are they try emphasizing American football at age 13 or tackle, things of that nature. So again, without the data, you can't make those injury prevention jumps. But very good there, Mr. Kim. Proceed.
Alrighty, well, thank you so much, Mr. Kim. Our next presentation is going to be from Sarah Francis, and Miss Sarah, if you, whenever you can, please share your screen and you can proceed.
All right, can everyone see my screen here? Okay, perfect. So hi everyone, I'm Sarah Francis, and I will be presenting the article called Injury Risk in a Tackle Ban in Youth Rugby Union, Reviewing the Evidence and Searching for Targeted, Effective Interventions, a Critical Review. And below listed are the authors and their respective affiliations. So to start off with a background, here this literature review took different articles and essentially pointed to the rugby union's proposal to ban tackle completely in school rugby. So before making this conclusive decision, it would require the identification, estimation, and evaluation of the risk. So this comes down to a few different things, and approximately 70 academic practitioners and public health professionals proposed that this tackle should be banned in United Kingdom schools. So with respect to injury surveillance in rugby union, especially with youth players, neither the incidence nor the severity of the injury have been identified in depth, and this is why these 3 points of identification, estimation, and evaluation are so crucial. And this stems from two main issues. One is that the availability and the resources of these qualified medical staff widely varies, so it can lead to inaccurate reporting. And two is that calculating the exposure accurately is difficult because athletes often participate in different activities, and the activities that are researched using data collectors are not always the sports that the athletes are participating on specific days. So essentially, the aims come down to a few different aspects. So first, it was important for the article writers to evaluate current evidence for injury risk of playing rugby union, specifically with youth populations. Then it pointed to identifying the gaps in both their evaluation and understanding how injury may differ across different groups and how that different definition may be different as well. And through these, they would be able to propose different future research designs and different intervention methods that would be able to reduce the injury risk. And through the data collection, this was done through literature review and synthesizing the current findings in a way that would both highlight the key features of the current research as well as identifying gaps in the literature. In terms of the main results, one of the biggest factors to consider when determining if a complete ban on the tackle would be appropriate is identifying how injury definition varies. So this comes down to injury epidemiology in youth sports. and especially with incidence and severity, because it is hard to obtain one sole definition for injuries. And at one extreme, an injury can be defined as a physical symptom that is reported by participants, and this can be regardless of whether medical attention was sought, while at the other end of the spectrum, as defined by the article, injuries were defined as those that cause a minimum of 7 days of time loss from training or from a match. So moving on from the injury definition, something else that was considered was rugby versus other sports. So below here in this last image at the bottom, we can see highlighted in red, these are 3 different sports: soccer, ice hockey, and rugby union. And it was seen in the article that there was not a significant difference between the incidence of the injuries in both rugby, ice hockey, as well as soccer. And these are only a few examples from the exhaustive list, but in the article, essentially, they showed that when looking at rugby versus other sports, there was not a big difference between all of them, and injury risk was something that was spread across the different sports. Moving into the age groups, so through the analysis of other papers, it was clear that approximately 15 years of age was that crucial time point. So after 15 years old, that is when the tackle was something that had to be considered, and the way that the tackle was used in the sport could have an impact on injury. So in this first image here with the letter A, we can see that this is a passive tackle. And this is what the younger players typically use. And as they get older, they use something called the active tackle, which was brought up in the article, and showed that with that, it caused greater injury. And that is something that needs to be considered when it is introduced either earlier on or later on in the athletic career. So through the article and a review of all the existing literature, there was evidence suggesting that the tackle type does change after adolescence. So this being said, it may increase the risk of injury, and this risk could also be tied to poor tackling technique. So the implication of these findings is that, one, it is suggesting that poor tackle techniques can play a critical role in injury, but also it is incredibly important to properly teach good technique and management of which type of tackle the young players are taught as they start the sport and as they grow older in the sport to have an effect on their injury risk. And in terms of the consideration, ultimately, the overall consensus was that although the ban of the tackle from schools rugby has generated a lot of debate, many research questions are still present, and these require further investigation. So in conclusion, the review did not support the proposal to remove all contact from youth rugby due to all those questions that are left unanswered, and a better need to understand all the incidents, the epidemiology behind the science in youth populations. But overall, rather than coming to this final consensus, they did provide objectives for the future and consider future research. So overall, 2 of the main considerations were the hybrid rugby tackle conditions, as well as the biobanding method. So in the hybrid conditions, this would include different tackle conditions based on age. So the idea here would be to keep the nature of the sport, but attempting to reduce risk. And so, for example, this would mean that laws could be targeted at various ages that would determine the legality of tackle types and the amount of contact. But the limitation here is that it would be difficult to standardize this on a global as well as national level. So moving on with something similar was the biobanding method. And in here, children would be grouped by physical maturity instead of by chronological age. And this would help reduce the mismatches. So since rugby is a physical contact sport, if there were to be any mismatches with physical differences, this would aim to alleviate that. But again, a limitation here is because psychosocial development does not always happen at the same rate as biological changes. The sport would have to be adapted in that way. And in terms of future directions based on this literature review, so one of the factors that could be considered for the future is the longitudinal injury surveillance in youth population. And one of the factors here that would show promise is harnessing the ability of using different technologies, such as both app or cloud-based data, to make the data collection more feasible. And this is one of the limitations that different countries are facing now and are not necessarily on the same page with. Achieving a greater consensus on reporting data. So This is important in properly reporting injury data, and this includes, as I mentioned before, establishing a common definition for injuries, and especially at the amateur levels. And finally, here, the last point for future research is video analysis study. And the tackle has been noted to be part of the game that causes the most injuries, especially among youth sports. And video analysis would assist in better understanding the risk factors behind injuries and being able to trace back what exactly in the sport or within certain games would trigger the injury and trigger either short or long-term interventions. So thank you very much. Here are my references, and I'm open to any questions that anyone may have.
Alrighty. Thank you so much, Sarah. It was a wonderful presentation and a very interesting study, I would say. I just have a small question. In your opinion, do you think proper tackling technique really alleviates the chances of suffering concussions? For example, as athletes, as we know, when they progress through the ranks and get older, they become stronger. So the intensity behind the hits is going to get much stronger, and the point of impact is going to be much more rigorous, as you know, for example, youth athletes. So in your opinion, do you think proper tackling technique is going to really alleviate the chances of suffering a concussion?
I think that it's definitely important for the education side of things at a younger age. I think that if adolescents, for example, or children under the age of 15 are improperly taught about tackling, this can translate into even more difficulties in preventing injuries later on. But I think there's a lot of complexity in terms of deciding fully whether or not to ban it completely. And I think that the obvious answer would be if we can avoid it completely with children and have them engage in a way that doesn't place any strain on the impact of a blow to the head, which would cause a concussion, that would be an easy fix. But in terms of looking at the difference between being under 15 and over 15, they do point to the fact that as individuals get older, there is an increased risk, and the physicality of the sport does increase. That I think in terms of concussions, proper education and looking at ways to involve the tackle that does not place a direct strain on the head could minimize the injury directly to that part of the body, but it doesn't mean that it would avoid injury to the rest of the body as well. So it creates sort of a gray area in that sense.
Great. Thank you so much.
That actually was an argument that the AAP offered a few years ago in support of youth tackling in football, was because when they're smaller, you know, and they can't tackle well, they don't have enough force to hurt anything, you know, so they're little light people banging each other. But then the older they get, and 15 is in a maturation age, you know, and so some people can be really big and strong. And if they have not ever learned correct technique, then they're more likely to hurt something or somebody else. So, you know, so the argument was teach them early if they mess up, they don't have a lot of force versus early. So it's just like, you know, riding a bike with training wheels versus riding a, you know, like a moped, you know, as an 8-year-old, you know, so it's just, you know, where you're most likely to get hurt, or when, you know, are you most likely to get hurt? I had a question on, I don't play rugby. I never did. I don't cover rugby. And I'm just wondering, you said they go from passive to active tackling. Do they continue the passive tackling and they just add on active tackling, or do they literally switch to the other one at 15?
So from this specific article, they had mentioned was passive tackling being more specific to the younger age groups, but it wasn't mentioned that this was eliminated completely as they got older. It was something that, when comparing the two, there's a higher rate of that active tackling as the individuals reach past 15 years old. But I'm assuming too that once you develop something as you're younger, I would assume that as you get older, you sort of still build on those old practices, the old ways that you're being taught within the sport, and continue to build in different tackling techniques.
That's probably where I guess I will state the science is not backing that at the moment. What happens is that we could assume a lot of this where the passive tackling is occurring in the youth game, where they're not fully tackling themselves. Maybe they're wrapping themselves. I think Dr. Coleman, you alluded to, they're smaller, they're younger, they're just kind of neutralizing each other while they're playing. They're not really per se laying each other out. I do think that I've seen that more so at the youth level now, at the under 14. There's a very big gap between under 12 and under 14 play, where under 14 play is really where they kind of acknowledge, oh, if I take this player out of the play, not necessarily out of the game, God forbid, I'm saying out of play, we can maybe win possession of the ball and proceed offensively. That would be probably the best way of wording it, where the 14 players now see the benefit, particularly with the involvement of sevens and the 7 versus 7 on the field. You can imagine being 6 players, 1 player down, it makes a big deal because now you have an entire soccer or American football size field that you can run around and creating an extra gap. So I could definitely see the active tackle being more of a concern at the maturation age. Also, athletes at that age, and Dr. Coleman can definitely affirm to this, are gaining major strides in their growth curve. This is where we get, a 14-year-old that's 6 feet tall, 15, this is what happens from 12 to 14. These are where the kids gain 3 feet in height, and it makes a big difference. And I think they do a great job. South Africa and Dr. Brown and their colleagues down there, emphasize the youth sizes for for scrums. So therefore, when the players come together in the sport, they're actually of similar size, and it's kind of important protective wise that they match the weights. And I guess that's where it comes out when the adults play rugby. They actually put on the screen the weights of their front linemen, in theory, for people who understand American football. So they'll put the pack weights and say, oh, they're off by 20 stones or 100 kilograms, whatever it is. What it is that they emphasize that because they know, obviously, at the adult level, the size does matter. When you were talking about this youth play, it gets really, really kind of tricky because it's hard to garner or to gather the players as it is to play a non-conventional sport, per se, or a non-trendy sport like rugby. So they try to get whatever players they can. But it's also very complex because you have to also take into consideration the referees. Luckily, they are trained in this, where they know if the packs look very different, they're going to make it uncontested. That means they don't go against each other. They just bind, and then the ball gets pushed through, and therefore there's less potential for injury, particularly when the packs come together with their cervical injuries or any spinal injuries of that nature. So they do a good job with it, but I do have to compliment the authors on this paper. They did a great job, Dr. Verhagen and Ross Tucker. They put this paper. This is probably the best paper on how you go against scientifically something that's said about your sport. They validated the lack of literature or science in which we had a bunch of clinicians sign a waiver in the United Kingdom, but this is how you defend against that, where you show the science does not reflect that. And I think that's probably for our major educational purpose here. This is how you defend your point of view at this high level. And obviously, Everett Verhagen is also on the International Olympic Committee, and Ross Tucker and Dr. Rafferty are both with the World Rugby. So it's kind of very unique for you to kind of get the bigger gist of where this is. I do understand the physicians and the clinicians coming from their perspective about attempting to ban tackling, but I think we have a lot of potential to do more work in injury prevention and injury surveillance that grows into injury prevention prior to doing anything else.
Excellent. Thank you everyone for your wonderful incentives, and thank you, Ms. Sarah, for the excellent presentation. Our last presentation will be from Mr. Sagar. Mr. Sagar, please proceed whenever you're ready.
All right. So the paper that I'm going to be presenting today at today's journal club, this one's actually very similar to the paper that Mr. Kim presented earlier. As you can see, it has the same principal investigator as well. Except this one is regarded more towards children and adolescents under 21 years old. And this was published in the British Journal of Sports Medicine in January of 2015. It has been 7 years, so there's been a lot of changes in the consensus and various scales that we use in World Rugby. Right, and now to look at the backgrounds and methods of this specific study, this was, they didn't actually go out and collect any sort of data. So what they did was they actually took all of the literature at that time, as of January 2015, they compiled all of this data. And what they did was they, firstly, they compiled all this data through databases such as PubMed, and these databases listed in the slides as well. And then they, each of the researchers in the paper also looked for papers regarding injury, specifically ones that had data related to exposure and as well as incidence. So what they did was they identified 634 papers through PubMed, 763 papers from Embase, and then 928 papers from here. And so what they did was, after taking these relevant studies, what they did was they calculated a pooled estimate in their analytics. What they did was they calculated this pool estimate of rugby union injury incidents, because there weren't actually enough studies on rugby league at that time to actually justify calculating pooled injury incidence estimates. And so they, in their analytics, they did some meta-analysis, log incidence rate, using their analytical tool of Stata. And that's how they did their analytical study. And so when we look at the results of this meta-analysis and this study, what they found was using the exposure data and the injury incidence, they used it to calculate probabilities of injury. And they did this in places where there were homogeneity in the data that they had regarding injury incidence. And so the final conclusions were, firstly, that the most common injury categories were ones in fractures and any sort of ligament and soft tissue injuries, as well as concussions. And they also, in the results, they concluded that being tackled was the main phase of play where these injuries occurred, with the data that they had compiled from all the literature past 2015. They found that 28% of rugby playing adolescents were likely to sustain an injury over the course of a typical season, and that 12% of these were likely to sustain an injury that had them gone from play for around a week or more. And so when we look at the bigger real world context surrounding this, what we find is that the increasing popularity and growth that rugby has come with, what it should also come with is an acceleration in the implementation of how we survey injuries and collect data on injuries surrounding the facets of rugby. And what we see is that studies that adopt this medical attention definition have the potential to record higher numbers of injury. Although the fact of the matter is that such data may actually be less reliable and not contain as many injuries that have actual significant clinical interest and importance. And lastly, we see that there is at this paper, what it saw was that there is a big need for significant improvement in injury surveillance in these departments and schools to address the challenges posed by rugby and other sports injuries in children and adolescents. And below listed are my references and my academic affiliations as well. I have the floor open for any sort of commentary if anyone would like to chime in. Thank you.
Very nice, Mr. Singh. So the issue here, and again, paper's a little bit older, 215. Particularly what happens is that there's been a lot of involvement in how they look and statistically analyze exposure and incidence. Moving into more looking at the overall incidence times time loss, which gives you burden. And so this is just, again, another good paper, foundational paper in which they looked at the literature review. Again, due to the fact that they could not standardize the data, there was a lot of heterogeneity between the data of the papers that they came out. A lot of those papers were early on. It's hard to really look at this and really garner what the incidence rates are. That's why community sport injury surveillance in rugby is really taken off in the past decade. Between Ireland, England, ourselves, major sports and soccer, they're really looking at the injury surveillance in youth and adolescents involvement in sports at a much better way, where the data can be inter-study comparable, you know, and therefore you have that standardization where you can make these assumptions, or maybe the systematic reviews are now stronger, and that really helps everyone on the planet, because you're taking data from all over the world, creating a systematic review, and then really pooling the data, because they're looking at excuse me, apples to true apples to apples, not apples to oranges. So they're really looking at the data appropriately, and this is really what I guess at the spearhead of what the tip of the IOC has been really trying to do with all their consensus statements. And even with gathering governing sport bodies, where they, for the concussion consensus statement, which includes FIFA, World Rugby, equestrian, racing, car racing, all these that where people could encounter these injuries, International Hockey Federation. So I'm just saying that these are the groups where they make these standard and the consensus statements really kind of impactful of what's going on. And we're very fortunate at this stage to be kind of in the mix of all of this with our group and with what we do. We're honored in that aspect, because this is really right now where we're looking at the data appropriately and really contributing to the sports themselves for injury prevention purposes. And yeah, like I said, it's really a great time for the whole planet and sport overall that the groups have really put this together, and let alone the IOC Centers of Excellences have been able to put all that around the planet together. Like I said, another good paper. Great job, Sagar, on that.
Thank you.
All right. So if there's no other questions, here is where we finalize our week 4 summer lecture series. A virtual round of applause for all our presenters. And I would like to thank everyone for presenting today, and a special thanks to Dr. Coleman for coming in today. We initially met Dr. Coleman in ACSM, and it was great seeing you again. And thank you so much for providing us with your wonderful insights. All righty. Well, thank you for everyone at home who's tuning in, and we're now signing off.